Hello, I'm Dr. Jay Noreen. Welcome to Health Talk. With the exceptions of polio early in the 20th century and AIDS beginning in the 1980s probably, no disease has had such interest, concern for finding a cure as breast cancer. We're fortunate here in the high country to have people with great expertise who specialize in breast care. So today we have the good fortune of having with us Dr. Ann Corinne Beaver of the Breast Center of the Watauga Surgical Group. Dr. Beaver, thanks for being here. We very much appreciate it.
Thank you. My pleasure.
You know, I'd love it if you could talk a little bit about how you got into medicine and into surgery and specifically into breast surgery.
Certainly. Well, when I was in high school, I wanted to be a doctor. I did. And I actually wanted to be a doctor and fly airplanes. And not all of that came to fruition, but I did go on to medical school. And in medical school, I thought that I would be a pediatrician, actually. I did have the good fortune while I was in college to spend some time abroad, and I spent some time in Africa at Kajabi Medical Center, where Dr. Dick Bransford, who now lives in our area, was working and has done wonderful things to help the medical community and community in general in Africa. But that stirred my passion for surgery. And when I was going through my rotations during medical school, at the end I had one stack of applications because it was a long time ago. You actually had to type them out. It wasn't online or on the computer. And one stack for pediatrics, one stack for surgery. And my heart and my passion just went to surgery. And so that's how I ended up doing surgery. I did try to talk myself out of it, though, because I knew it would be a hard road. And but I'm really glad that I stuck with what I felt like in my heart I wanted to do. And I think that's true for most things. People should follow their passions.
Yeah.
So, and while I was in my surgery residency at that time, I trained in the Southeast, and there weren't very many women in surgery at that time. Now that has changed, but at that time there were very few women training or women surgeons. So I knew that I would be doing a lot of breast surgery just by fact of my gender.
Sure.
But as I started learning more and more about it, I also discovered I really enjoyed learning about it, doing it, and it's a very exciting field because there are so many new developments every year based on research and evidence-based medicine. So it's a very exciting field to be in.
Yes. Well, it's wonderful that you chose the field you did. My family has the good fortune of having a woman surgeon, and we've been very, very, very pleased. So.
Okay.
I know surgical residency is a hard road to hoe, and I did internal medicine, so maybe I took the easier route, although my internist friends won't agree with me.
That was a hard road, too.
Yeah. Well, it would be great if we could start off and you could give us some sense of what are the signs and symptoms that women should think about if they might be concerned that they ought to get something evaluated as a possible breast cancer risk.
Certainly. Well, I still think that it is important for women to do a self-breast exam. A lot of people will say, and you'll hear a lot of things on the media, that women should not do a breast exam because they will feel something and it's probably not something and it will cause anxiety and stress. However, I don't think that women often give themselves enough credit. And by doing a monthly self-breast exam, then they get to know the usual lumpiness of their tissue and of their body, and they get to know their body. Certainly if a woman does a breast exam and feels anything that feels like a small marble, a piece of gravel, if the skin becomes thickened or reddened, if she has bloody nipple discharge, or if something just does not seem right. In those cases, it's very important to go ahead and to call your primary care physician to go ahead and start the process going. And certainly, we see a lot of patients in our practice, and I tell them they could always give me a call as well. Be happy to go ahead and get the process going.
Now, how often should women do breast self-exam? And is there a particular time that they should do it, or any other guidance you might give?
Well, Ideally, they coordinate it with their menstrual cycle. However, it's very hard for people to remember. And so sometimes I just simplify it and say, do it at the first of the month, because people can remember that.
Sure.
And otherwise, it's very hard to remember, did I do it? Did I do it, or I need to do it on the 17th? And it just gets too tricky. And I think the more we simplify things and make them easier in hectic lifestyles, the more likely they are to get done.
Yeah, wonderful. What's the prevalence? What's the nature of breast cancer in America today? How frequently? Can you give us a little summary of that?
Sure. Unfortunately, breast cancer is too common. 1 in 8 women will develop breast cancer in the United States. That's a very high number. Based on the National Cancer Institute estimations for 2015, this year, over 231,000 women will develop invasive breast cancer in the United States. And on their estimation for 2015 as well, an estimated over 40,000 women will die from breast cancer in the United States. And also on their estimation, over 60,000 women will develop non-invasive breast cancer, or the very, very earliest form. So we're seeing a very high prevalence of this in the United States. However, the good news is that overall, breast cancer death rates are decreasing. And we attribute that to multiple factors, but one is better screening, early detection, and certainly much better treatment plans as well. So we're making progress, but we're not where we would like to be yet.
But the prevalence, the 1 in 8, has that been fairly stable? Has that changed over time? Or what would you say about that? Or is that clear?
Well, I think that's where you really have to start breaking down to a particular woman's risk for breast cancer, because there's great variability there. Certain people, certain ethnic heritage, or if there's a strong family history of breast or ovarian cancer in their family, their risk may be different than someone else. And so when we say 1 in 8 and the general lifetime risk of about 12.3%, that can vary greatly depending on who you are, your genetic makeup, and things like that.
So you mentioned that it's not only a family history, sisters, daughters, mothers, grandmothers, with breast cancer, but also ovarian cancer correlates with breast cancer. Is that right? If you have ovarian cancer history in your family, that increases the probability of breast cancer as well?
Well, we've found that there are certain genetic mutations that we can actually know about, where certain cancers travel hand in hand, if you will. So we know of at least 8 different breast cancer genetic mutations that we can test for, where there are other associated cancers with that. So.
Now, there are some of those that actually appear in the newspaper, some of those names of...
Yes.
Can you give a couple of the ones that people will read about, so when they see it, they'll say, that's what she meant by that genetic characteristic?
Sure. The very popular one is Angelina Jolie,
Yes.
whose mother unfortunately died from breast cancer. And Angelina Jolie had one of the 2 more common types of breast cancer mutations, BRCA1 and BRCA2, which we have known about for some time, and those were the ones we tested for. However, within the last few years, we have expanded our scientific database and scientific knowledge, and now there are multiple other genetic tests that we can test for. And this is something that I've actually changed just this year in my practice after going to my American Society of Breast Surgeons meeting, is that instead of focusing on just 1 or 2 genetic tests, now I get a genetic panel in appropriate patients, and we are capturing, we think, about 5 to 11% more of the genetic mutations that we were missing. We were just testing for the BRCA1 and 2.
That's a big increase.
It is a big increase. And so I think with that, and this has been something that has been changing in terms of taking care of breast cancer, is that we must keep an open mind. And in terms of genetic testing, it warrants a very good discussion with a physician or a genetic counselor before pursuing that test. Most of the women who develop breast cancer, though, do not have an identifiable genetic mutation, even if they have a family history of breast cancer at this point.
Who should get the genetic screen, the panel you're talking about that's available now? Should everybody get that, or should certain people with risk factors get that, or who should get the screen?
Yes. Well, I think first of all, when you do genetic testing, you want to test the person in the family who actually has cancer. They should be the ones to be tested because that will give you the most information on whether that genetic mutation exists in the family or not. But not everyone is a candidate really to have the genetic test performed because their risk factors may be very, very low to have that genetic mutation. So it's very important to talk to a physician who understands genetic testing, knows what is happening this year in terms of genetic testing. We only have about 4,000 geneticists in the United States, but we do have many other genetic counselors. And actually here in Boone, we have ways to set up through Skype at the Cancer Center and to talk with a genetic counselor if someone is interested. And we do have certain genetic centers where we refer people about 2 hours away, so they can have genetic testing if appropriate. Now, for people who do not have cancer, I very much recommend that they should talk to a genetic counselor before having genetic testing. Because there are certain ramifications of genetic testing beyond just the medical aspect, and that has to do with insurances and things like that. As well as personal ramifications, and so they must talk to a genetic counselor before getting genetic testing, and I'm very particular about that.
Now, where would people find a genetic counselor? And you say you can do that by Skype connection or video connection, that sort of thing, pretty easily.
Yes.
Would they do that with you or with their primary care physician, or what's the best way to do that?
The best way to do that is probably through someone involved with cancer care to begin with, and they would have the resources to direct them to someone appropriate.
Yeah, so your surgical group or an oncology group or something like that.
Correct, or the cancer center, yes.
Sure. Okay, great, good. Now, you mentioned risk factors, some of which would dictate genetic screening and other things, and of course family history is one. Are there other risk factors that people should take into consideration as they're thinking about what is my risk of breast cancer?
Certainly. The things that we do for good health also translate for good breast health. For example, it's very important to maintain a healthy body weight. Excess body fat puts someone at an increased risk for breast cancer. Recently at our meeting, again this year, we talked about for breast cancer survivors, if they exercise some type of aerobic activity, like jogging, walking 5 times a week, eating vegetables and fruit, low fat, not too much protein in their diet, certainly not too much wine or alcohol, and maintaining a healthy body weight, their risk of a recurrence of breast cancer can be reduced as much as 50%.
Oh, really?
And
50%? That's
very significant. But these are things that we all know we should be doing. We should all be exercising, eating a healthy diet, and really I think the thing that we could work on more is trying to maintain a healthy body weight.
And that has correlation with all kinds of other issues.
It does.
Diabetes and all kinds of other issues as well. So we have lots of argument to be careful about body weight.
We do, but we actually have a new program that's being set up at the Wellness Center called Thrive, where if someone is interested in a program, they can go and sign up, and they meet with a nutritionist. They have a class, they have a sports trainer, behavioral therapist. So it's really a wonderful program that's being started and available up here as well.
Okay, now where is for those who might not know, where's the Wellness Center?
It's the Boral Hill Wellness Center on the street that just cuts right through from off of 321 as if you were driving to our office, actually. But in any event, it's the Boral Hill Wellness Center that's affiliated with Appalachian Regional Healthcare System. The best directions would be provided on the Appalachian Regional Healthcare System website, where there's actually a link to that.
So look up the Wellness Center on the website, and you'll find it.
And don't let me drive you there. Exactly.
Can we talk a bit about mammography, the screening? It would be interesting and I think useful to the audience if you could describe, especially for the first time mammography, what's the experience like for a woman to have a mammography?
Certainly. Well, we have come a long way in terms of mammography to begin with, and still mammography is the best screening tool for breast cancer, even much better than a breast self-exam. And so mammography delivers very little radiation as well. Some people are concerned about that, but it's the equivalent of living on our planet Earth about 7 weeks.
Oh, wow.
So that's not very much at all.
No, that's for sure.
Okay. And simply having a mammogram is very easy. You go in and the mammography technicians will take images in 2 dimensions of the breast. So, and it can easily be scheduled. Here at Watauga Medical Center, actually for a screening mammogram, a woman can even call up and make her own appointment.
Oh,
and have
really
it sent
simple.
then to your physician. Mammography, though, has been taken a step further in recent years. We used to have just plain X-ray mammography. In 2008, here in Boone, we switched to digital mammography, which increased the sensitivity as well as the image quality. I used to tell people, think about, you used to take a picture with an old Polaroid camera, and then now you have a high resolution, high definition camera. And now we have 3D mammography here in Boone, which was installed in August. And this has markedly also increased the sensitivity of picking things up. Having the 3D mammogram is actually very similar to having a 2D mammogram. So on a 2D mammogram, each breast is compressed once this way and then once this way. And think of it as a snapshot being taken. With 3D mammography, when the breast is compressed, instead of just one snapshot, briefly a scan goes over. And this allows multiple thin slices that then a computer program can put together many, many images of the breast. And so we've gone from 4 images, 2 images on each breast with regular 2D digital mammography, which is still quite good, to now having perhaps even hundreds of images on each breast. It's especially helpful for women who have dense breast tissue because you get less overlap of the tissue. It's especially helpful for younger women who tend to have more dense tissue, as well as sometimes things are seen that are not really there. It can cut through that, and so we have fewer what we call false positive rates, or calling something that really doesn't exist. And so it has really been a good revolutionizing technology for breast imaging. And fortunately, here at Watauga Medical Center, they're doing 3D mammography on all patients, which is also very important. Not all insurances cover this, but this is the only facility in our region who is doing it, and the hospital is simply absorbing the cost right now and not going to charge the patient more for the 3D over the 2D cost.
And this is brand new, you said just in August.
It is, and it really has an increased sensitivity rate from anywhere, depending on the study, from 17 to 41% increased detection rate
That's huge.
of invasive breast cancer.
Yeah.
Yes, as well as a markedly decreased reduction in having something called that's not really there, even up to 40% as well.
Oh, wow.
So it really is revolutionary, and it's very wonderful that it's being offered here to our community.
Yeah.
Absolutely
Now, will this
great.
eventually replace 2D mammography, or is that an open question at this point?
Well, I think what we'll see is there will be a lag effect in terms of the recommendation, because most of the studies now that we have to wait a period of time when the study is completed, the research study, and so we might have to wait 5 to 10 years But the problem is the technology changes in 5 to 10 years.
Sure.
And so what we're doing now, we might not have the effect until 5 to 10 years from now, but we already know that the image quality is much better. And the American College of Radiology has come out with a statement saying it is the superior mammogram to have. And that came out in one of their statements in November of 2014.
So the big benefit is it's here in Boone and available and being broadly provided to
Right.
the patients.
We're very, very excited about
Yeah.
that because it's just going to improve breast health.
Sure.
Cut down on fewer biopsies that don't need to be done, as well as doing more accurate biopsies when they are indicated,
Sure.
and hopefully finding breast cancers when they are earlier.
Very early, yeah.
Yes.
That's exciting. That's
It's wonderful.
Now, there have been, just recently, the American Cancer Society came out with new guidelines for screening mammographies.
Yes.
Can you tell a little bit about what those guidelines are?
Certainly. The guidelines have been evolving over the years, as guidelines should, because as we learn more and more information, have compiled more data, and can do more evidence-based medicine, we should always be reevaluating our guidelines. So the guidelines that came out and really became very public about 2 weeks ago suggested that mammograms might begin at age 45 instead of 40, and then some mammograms be every other year. Now then, as with any guideline, we have to step back and say these are just guidelines, because what's very important is to understand what is a woman's personal risk for developing cancer, because not everybody is in the same category. Some people have a higher risk of breast cancer based on their family history, or they may have very dense breast tissue where it might be harder to see something. So it's very important to sit down with your physician or primary care provider or breast surgeon and talk about what is appropriate for that patient to have a mammogram and how often.
So even despite that 45-year-old guideline is there, the advice is talk to your primary care physician and see if you should maybe have it earlier because you have some risk factors or not. Don't just assume you should wait till 45.
That's correct. It's strongly recommended between age 40 and 44 that there's consideration of a mammogram, and then from 45 until 54, annual mammograms per the American Society of Breast Surgeons guidelines, and then from age 55 beyond, consideration of every year or every other year. But again, it goes down to an individual woman's breast history, as well as their risk factors as well. And then there is no cutoff date for mammograms. It depends on the life expectancy of that particular woman.
Sure.
If a woman is expected to live another 5 to 10 years, then she should still have a mammogram under our current guidelines.
Okay. So the main message is consider doing them early.
Yes,
And
yes.
in consultation with your
Right.
physician. Now, the step of a biopsy. How are breast biopsies done, and how are they done in Boone? Can you talk a little bit about that? Because a lot of women face that when they get a mammogram that results in you need to do a biopsy.
Correct. These days, we do minimally invasive biopsies. So many times what we're finding on mammogram or perhaps ultrasound might not even be something that we can feel. However, in our office, we can do an ultrasound-guided, minimally invasive biopsy and use a very special biopsy needle device. Now, the patient is actually awake and has local anesthesia, and it's very quick and gives us the results that we need. Likewise, we can also do minimally invasive biopsies under mammography called stereotactic biopsies, and we just actually got a new stereotactic biopsy machine installed in August as well. And this is where we can actually take mammograms of a woman's breast, make a very small incision on the breast after giving some local numbing medicine, and go in with a biopsy needle device. Both of these are about the size of IV tubing, so very, very small, and take very rapidly some samples and get a result that way. So we typically do not go to the operating room to do a biopsy.
That's good news. That's good news, I'm sure.
It's much better for patients.
Now, we cannot cover all that we need to cover in the session we have. We want to have you come back sometime, we hope. But can we talk just really briefly about what are the treatment options for someone who has a positive biopsy?
Certainly. So many times we do breast conservation treatment in the United States, which involves removing a lump of tissue around the cancer, and we just have to have no cancer cells on the edge of that lump.
Is that a lumpectomy? Is that
a lumpectomy,
yes.
and it is not as big as what we used to do.
Okay.
So it can be
even
very
more
small,
conservative.
even more conservative, and then with that, then we do radiation treatment, and it's 3D conformational radiation treatment, where we use a CT to guide it directly to the area where the cancer was, as well as radiating the rest of the breast. And that is also provided here in Boone. Then, depending on the actual genetic features of the cancer, we decide whether or not chemotherapy is needed.
Okay.
As well as many times women are a candidate to take a pill daily. It used to be for 5 years, now it is for 10 years for most women.
Okay.
So.
Wonderful. Well, listen, this has been so instructive and valuable, I hope, to the audience that's listening. We have more to talk about, and so we hope there'll be a time when we can get you back and go to the next level of discussion about this very, very important topic.
Well, thank you.
And thanks for being here. We appreciate it very much.
Thank you. Enjoyed it.
Thank you. Well, that's our program for this week. If you do have questions or comments, you can contact us at watchapptv.com. That's watchapptv.com. And please join us again for Health Talk here on App TV. I'm Dr. Jay Noreen.